Keratosis pilaris. Definition. Keratosis pilaris is a disorder characterized by keratinized hair follicles. Monomorphic, follicle-based papules with a central horny spine are located predominantly on the extensor upper arms and thighs, with the cheeks of face less commonly affected. Keratosis pilaris, minute, rough, slightly inflamed papules on the upper outer arm. Incidence. Almost 1/2 of the population is affected by keratosis pilaris. It is most common in adolescents, especially those with a history of dry skin, as seen in patients with atopic dermatitis and ichthyosis vulgaris. A positive family history is often present. History. Patients often report rough bumps that do not go away with washing, especially scrubbing. The condition is often mistaken for acne. Keratosis pilaris is not pruritic or painful. However, patients do not like their bumpy appearance. Signs and symptoms worsen in the winter and improve with age. Physical examination. Keratosis pilaris is characterized by individual, small, follicular papules with a central horny spine. The lesions can be non-inflamed or inflamed. Keratosis pilaris is monomorphic. Common areas of involvement include the cheeks and extensor upper arms and thighs. With facial involvement, background erythema is commonly seen. The lesions are present in a symmetric distribution, example. Both upper arms or cheeks are affected. Keratosis pilaris. Minute rough papules, sometimes better felt than seen, with background erythema on the face. Differential diagnosis. Clinical recognition makes the diagnosis straightforward. When keratosis pilaris occurs on the face, it is often diagnosed mistakenly as acne. To distinguish acne from keratosis pilaris involving the cheeks, look for pustules and comedones that are diagnostic of acne. Lichen spinulosus, which can appear clinically similar to keratosis pilaris, has a sudden onset, is located most commonly on the abdomen, extensor arms, knees, and neck, and may remit spontaneously after 1 to 2 years. The papules of lichen nitidus are flat-topped and not as rough as keratosis pilaris. In addition, coebnerization, linear streaks of papules, is seen in lichen nitidus, not keratosis pilaris. Differential diagnosis of keratosis pilaris in clud. Acne. Lichen spinulosus. Lichen nitidus. Laboratory and biopsy. Keratosis pilaris is a straightforward clinical diagnosis. Laboratory workup and biopsy are not necessary. Therapy. Education and reassurance are the mainstays of treatment. It is important to recognize that keratosis pilaris can be cosmetically distressing. An emollient cream can soften the rough papules. Therapeutic emollients containing 20% urea, Carmel 20, salicylic acid 6%, Keralit. And ammonium lactate 12%, Lachydrin, prescription only, or amlactin, available over the counter, have keratolytic properties, thereby decreasing cornea site adhesion. Tretinoin cream 0.05%, Retin-A, or over-the-counter adapalene gel 0.1%, Ifaclar, can also be used successfully. Therapy for keratosis pilaris. Initial. Reassurance and education. Therapeutic emollients. Urea 20%. Salicylic acid 6%. Ammonium lactate 12%. Alternative. Tretinoin cream 0.05%. Adapalene gel 0.1%. Course and complications. Keratosis pilaris can improve with age but tends to be persistent, especially in individuals with a history of dry skin, example, ichthyosis vulgaris. It can be associated with post-inflammatory hyperpigmentation in darker skin types. Complications are uncommon. Pathogenesis. Although the etiology of keratosis pilaris is unknown, abnormal keratinocyte desquamation most likely leads to keratin plugging of the hair follicle.
Clinical case. A 16-year-old girl presents with multiple small, rough bumps over her upper arms and thighs for the past 2 years. The lesions are asymptomatic but cosmetically concerning. On examination, there are numerous follicular, keratotic papules with a chicken skin appearance. The surrounding skin is slightly erythematous. No pustules, comedones, or significant pruritus are noted. The patient is otherwise healthy. What is the most likely diagnosis? A. Acne vulgaris. B. Lichen spinulosus. C. Lichen nitidus. D. Keratosis pilaris. E. Folliculitis. Correct answer. D. Keratosis pilaris. Explanation, concise and high yield. Keratosis pilaris. Follicular keratotic papules. Common on extensor arms, thighs. Chicken skin texture. Usually asymptomatic, chronic, adolescence onset. Why not others? Acne vulgaris, comedones, pustules, inflammatory lesions. Lichen spinulosus, sudden onset, group spiny papules, often plaques. Lichen nitidus, tiny, shiny, flat-topped papules, often genital, abdomen. Folliculitis, pustules with inflammation, infection signs. Thank you for your attention.